evaluation of culture, race, and cultural competence in healthcare. And those of you who know Jennifer know that her work is from sociology, and she does a lot of work around medicine, race, and healthcare, and equity and inequity in healthcare systems. So, thank you, Jennifer.
Well, thank you. I'm really excited about this group, and I appreciate Jana and Taft organizing both the Medical Humanities group and the lecture series. It's also really fun to see people who I know in so many different service and different personal ways here in the audience, and to get a chance to talk about some of my research today. And as you can see on the slide, this research itself was supported by a grant from Taft from when I was on sabbatical, which sadly was 2 years ago, and I'm still working on this paper, but really a lot of the progress got made while I was on leave. And I also thank Jeff Jacobson, who's here in the audience, and my neighbor, for some advice he gave me when I was working on a revision of this paper at one point about culture. So, and some of my sociology colleagues as well. So, what I'm going to talk about today is cultural competence in healthcare. And cultural competence is defined in lots of different ways. Sometimes it's talked about as a skill for an individual healthcare provider. Sometimes it's talked about as an institutional goal. It's a type of training program. And in all of these forms, it's thought about, well, in the ways that I'll talk about it today, it's thought about as a way to reduce racial inequality in healthcare. And this paper critically examines articles that have been written about cultural competence in healthcare and the programs that the articles describe. I argue that this cultural competence approach to solving racial inequality in healthcare reflects the broader racial ideology that we have right now in the United States, and that this ideology serves to obscure and to justify inequality on a lot of levels, instead of focusing on power and why we have inequality. So while it appeals to dominant notions about racial inequality, I don't think that it can, I was going to say solve, it can't even help solve, in my opinion, the problem of racial inequality in healthcare. So if you think that cultural competence is a great thing, I'm sorry to say this whole thing is going to be about how it's not. So, but that's what sociology does. We often are the critical bearers of bad and depressing news with very little idea about how to fix things usually. We tell our students that's not what we do, that's policy. What we do is use our theory to talk about inequality. Okay, but so let me give you some background. This is a picture, an image of a book that came out in 2003. It's from the Institute of Medicine, and it documents racial inequality in healthcare. Hundreds of studies before this and since then show that whites are more likely than people of color, particularly African Americans and Hispanics, to get appropriate medical treatment when they go to the doctor. And that includes, if you go to the doctor, you go to the emergency room with a broken bone, getting appropriate treatment for the pain that you would have for that, as well as advanced procedures like coronary artery bypass graft surgery. Whites are more likely to get that than African Americans and Hispanics. So there's a lot of research that shows that this is true, and I would say this point probably of this book around 2003 started the turning point of less documenting that this exists and more trying to figure out why it exists. And certainly trying to figure out why it predates it, but now the research is almost exclusively focused on why. And I have notes today, which often I just talk off the top of my head, but were I to do that, we would be here for 90 minutes. And my own apartment has this room next, so I can't step on their right to the room. So my notes for hearsay, briefly. I cannot spend too much time talking to you about the explanations. There are sort of three categories that empirical research on explanations for this difference fall into. And I'm going to briefly tell you them and whether the evidence suggests they're true or not. The first is access and source of care. And access and source of care are explanations. Greater likelihood among whites of having insurance, coverage at all, private insurance in particular, make it more likely that you get better care, obviously. And source of care. Just like our neighborhoods are segregated, our clinics and hospitals tend to be segregated too. And some more recent research suggests that the quality of the treatment you get depends in part on where you go, and that there are different practices in different locations, and that might help explain racial inequality in healthcare too. Another type of explanation is patient preferences. And clip art is fun, isn't it? You like clip art? I've got one more good one after this. But this idea is not true. Early researchers, white researchers, thought maybe it's that African Americans say, no, don't give me the best, most modern treatment, or I want to have pain. But of course, that's not true. And one study, there's lots of studies that I could get sidetracked telling you about, but one study showed that 90% of patients who were appropriate for the example of coronary artery bypass graft, 90% of them, it hadn't been recommended. Doing chart review. They weren't even suggested that they get it. So often what people don't get is because they weren't offered it. And then the last explanation is provider bias. And this blurry picture of a hospital setting is a good visual representation of the theory behind this. It isn't that people think that doctors are racist and maliciously treating patients unequally, but social cognitive theory suggests that when you have a stressful cognitive load, you have a lot of ambiguity, a lot of things to attend to at one time, people are more likely to rely on, well, schemas or stereotypes. And so they get applied to patients sometimes. So the research does suggest that this is also part of what goes into it. Okay, so it's in this context of a problem and the research that's been done that we find this solution of cultural competence in healthcare. The idea that we should teach doctors about non-white groups' cultural characteristics in order to reduce racial inequality in healthcare, or at least as part of the solution. So let's look at what this cultural competence literature and area is about. The history of it is one that I feel fine about, is that the idea started with trying to improve care for immigrant groups, for people who are coming here from another country. You obviously need access to a translator to receive appropriate medical treatment and communicate with providers. And there are vast cultural differences across some societies in the US in terms of what to expect from a healthcare encounter and how to interact with doctors. What's interesting is that then it gets applied to racial inequality in healthcare. We have this problem that I described earlier, and then cultural competence starts moving into trying to use the same approaches, which actually I need to back up and explain, the same approaches to trying to improve treatment of non-white patients. So let me back up and say something though. The way the early cultural competence trainings went, and still often do, is about teaching a whole list. It's like a training that involves a whole list of things you should know about other cultures. So, Hispanics are more religious, and you shouldn't touch some groups. What groups is it, Jeff? Do you know? Vietnamese on the head. I read a really funny essay that went, "Who wants to be touched on the head?" But anyway, so listing lots of characteristics of things you should know when you're interacting with particular groups, starting with immigrant groups, where you can imagine a clinic where you're seeing a lot of patients from a particular country. This makes a lot of sense. But when you're talking about people who all live here in the United States, the cultural differences are usually, as I will argue, not the problem that you're facing. And in this imagined scenario, applying it to race, and the way it gets taught, they're always imagining a white doctor. So they're never teaching about white culture. The thing you should know about white people is they always think they're white. No one's ever saying that. Okay, so it's an imagined white doctor. And this idea of moving this cultural competence training from immigrant groups to teaching about people of color in the United States had critics from within the